ಈ ಆಡಿಯೋ ಕೇಬಲ್ ಇದೆ ಮಾತಾಡಿರಿ ಚೆಕ್ ಫಸ್ಟ್ ಸ್ಟಾರ್ಟ್.
Hello?
Yes, sir.
Yeah, sorry, Mr. Something in the YouTube they couldn't get the audio, but they got it now. So let me restart the conversation again. My topic is on role of ERCP in acute pancreatitis. And the role of ERCP in acute pancreatitis is quite controversial because we have to balance the risk of doing this procedure against the benefits that come. And if you look at all the causes of acute pancreatitis, gallstone pancreatitis is the one where ERCP has shown to be most beneficial. This has come out of the hypothesis that stones which are impacted at the lower end of the papilla, or the bile duct, can result in reflux of contents into the pancreatic duct and result in pancreatitis. So if you remove the stone here, then the reflux goes off and the pancreatitis resolves. And again, on this basis, all the ERCP has been started in this situation. But unfortunately, although it's as simple as this, if you look at number of studies that have been published, it's very controversial. I'm just giving you a total figure of all the studies. There are many controversies in this. Not to go into individual studies, but just to show you that in these studies, there have been very variable results. For example, the first study which came from Leeds in London in 1988 showed that in all patients with severe predicted gallstone pancreatitis, an ERCP was beneficial to the patient if done within 72 hours. The next came the Hong Kong study, which showed it was effective if there's cholangitis. But unfortunately, the next major study that came from Germany showed that ERCP was harmful in these patients and that ERCP was associated with respiratory failure. The reason why these studies had different results was because there were different timing of ERCP, the exclusion criteria were different, endoscopy expertise was different, and there were, of course, heterogeneous group of patients that were present. Therefore, doing studies in ERCP in acute pancreatitis is very, very difficult. But based on these studies, RCTs came. Based on these RCTs, we had many meta-analysis. And to look at the last one, which was probably the most conclusive from Petrov and others, who showed that overall complications and mortality in acute gallstone pancreatitis is not affected except when there's cholangitis. So if there's cholangitis, ERCP is beneficial. Now, why are we discussing this so much? The reason is not all ERCPs are easy or safe, especially in patients with acute pancreatitis. Not all ERCPs are safe, and you can see that the papilla can vary from patient to patient. In fact, if you look at the papillas that are there in patients with gallstone pancreatitis, you can see that these papilla very abnormal. So actually cannulating these papillas may be difficult. And this was a study from Marty Freeman's unit who showed that if you fail in ERCP in a patient with acute gallstone pancreatitis, the complication rates and the reintervention rates are extremely high. And therefore, you should be very careful when you do an ERCP. Now, this can also not only result in pancreatitis if you fail, but can result in infection or the necrosis because you are going into the pancreatic duct. It can increase the bleeding because the mucosa is very friable. If you inject contrast, cholangitis, and even perforations have been reported in this situation. And therefore, because of these potential complications of ERCP in acute biliary pancreatitis, we have to be very careful which patients we do. Fortunately for us, I think the advent of endoscopic ultrasound has solved the problem. It is now believed that in all patients with suspected acute gallstone pancreatitis, where ERCP is indicated, we must do an endoscopic ultrasound to be sure that there is a gallstone or sludge in the bile duct before we proceed for ERCP. And this is very obviously clear from this very nice study which came several years back from Hong Kong. These are 140 patients of acute pancreatitis suspected to be acute gallstone pancreatitis. Now, 70 of them underwent endoscopic ultrasound first, and 70 went directly for ERCP. And let's see the result. You can see that 70 who underwent endoscopic ultrasound, 45 of them had no CBD stones, which means ERCP would have been wasted. And those in whom CBD stones were present, all of them ERCP could successfully clear the CBD. The morbidity was only 7%. Now, if you look at 70 patients who went to ERCP, you will see that the success rates, 40% had no CBD stones. That means ERCP unnecessary done. And those who had CBD stones, success rate was high, but morbidity is very high, 14%, double that of US guided. So we believe now that EUS should be done in all patients before ERCP to confirm. And this is another European study, multiple European studies which have shown that the morbidity for ERCP direct versus EUS guided ERCP is very high. And therefore, we don't do ERCP directly in these patients. We have to have a strategy of EUS before ERCP for acute biliary pancreatitis. And this would be a better alternative to then trying to do a diagnostic ERCP. So let's sort of summarize what we have here. We believe that in patients with acute gallstone pancreatitis, irrespective of the severity of pancreatitis, if there is cholangitis, only an urgent ERCP is required. If there's no biliopancreatic obstruction, no endoscopic intervention should be. This is very, very important point that I'd like to emphasize to all the practicing gastroenterologists. that if you have a patient with acute pancreatitis, even gallstones are present on ultrasound. If on endoscopic ultrasound there is no evidence of biliopancreatic obstruction, we should not go for ERCP. This will cause more damage. Now let's come to the last group, and this is a very interesting group. The group of biliopancreatic obstruction with no cholangitis, but there is these patients should we do an ERCP. So no cholangitis, but obstruction is there, a stone is detected. Should we do? For this, we didn't have an answer for long, but now we have an answer. This is a study which was just published recently in Lancet, a Dutch study from multiple hospitals. What they did is they took 232 patients who had gallstone pancreatitis, but did not have cholangitis, only cholestasis. That is obstruction, but no cholangitis. Divided them into two groups, those who had early ERCP within 24 hours and those conservative treatment. And they took the primary endpoint as death or major complications. You see that either when they did ERCP or conservative treatment, there was no difference, which means that if the patient does not have cholangitis, only CBD is shown with jaundice, you need not do an ERCP emergency. Only if these patients on conservative treatment develop cholangitis, as 10% did, then you have to do an ERCP. So we have the final answer for this last block also. So biliopancreatic obstruction, no cholangitis, no need for urgent ERCP. It's very important, remember urgent. Maybe these patients will require an ERCP later on if they develop cholangitis or jaundice is progressive or pancreatitis. Now, how early is early? When should we do an urgent ERCP? Usually we used to think it was 72 hours, but this has changed now. Now we know that it should be between 24 to 48 hours or as early as possible. The reason this is important, this is a very good study which came from Argentina, where patients with gallstone pancreatitis had surgery and they looked at the amount of pancreatic necrosis. And you can see the pancreatic necrosis is very less in 24 hours, more in 48 hours. And by 72 hours, the pancreatic necrosis has markedly increased. So if you want to prevent this amount of pancreatic necrosis, you have to intervene before 48 hours. So the pendulum has swung now. We used to think very early 6 hours, later on 72 hours. Now we are fairly sure that you must do an ERCP before 48 hours if you want to save these patients with gallstone pancreatitis. Why this is important? This is important because if you have a planned ERCP like this, you have everything under control. You have 2 or 3 assistants, all the accessories, everything. But if it has to be done in emergency, urgency, then you'll see that nothing is under control. You don't have proper assistance. You have only one person to help you. And therefore, it becomes extremely difficult. And that's the reason why planning an ERCP in acute gallstone pancreatitis is very important. You have to do it in the office hours. You have to do it within 48 hours after the onset of pancreatitis. But this is not often easy. In fact, this is a study from the British audit. They looked at all the hospitals in Britain, whether they're following this particular thing to say whether they're doing ERCP before 48 hours. And you can see that only 8.7% of the hospitals actually did an urgent ERCP. So even in a very good system, not easy to follow these guidelines. But it's important to remember that early ERCP within 48 hours in patients with gallstone pancreatitis and cholangitis should be our goal. So if we have a patient like this who's come with acute gallstone pancreatitis, we use a needle knife to cut on top of the papilla here. And you can see the white pus already coming out. As we cut the papilla open, you can use a needle knife in majority of these cases. You'll see pus which is coming out. There's a small stone with the tip which I can dislodge with my needle knife itself. And when the stone is discharged, you can see the pus that is coming out. And this patient will obviously have a dramatic relief. Also in our countries, both in India and Bangladesh, you must keep account of this. This is ascariasis, a dead worm, which got at the tip of the papilla and then produced severe cholangitis, and this can be very easily. Similarly, hydatid cysts can actually block the papillary orifice, resulting in severe pancreatitis. So these are things that we should keep in account in our country. Now, before I end, let me come to 2 very important concepts that I want to discuss about. This is especially in patients who are undergoing ERCP for gallstone pancreatitis cholangitis. There's a very interesting concept that in addition to clearing the CBD stones, if in addition we can put a small pancreatic stent in these patients, maybe we can also decrease the progression of pancreatitis. And this was a study done by one of our students in published in Scandinavian Journal of Gastroenterology. He was Isto from Hungary. And you can see 150 patients, they could randomize into two groups, those who had PD stent along with CBD clearance and those who had only CBD clearance. And if a small PD stent is put like this along with CBD clearance, the study has shown very clearly that these patients will benefit. Those who are likely to develop a predicted severe pancreatitis don't develop severe pancreatitis, only mild pancreatitis, which goes off. Infected necrosis comes down and so on. So this is a food for thought. Maybe we can think of this in our patients. Second concept that I'd like to show you is that there's this concept that if you have an acute pancreatitis and the patient is not settling down, there's a leak from the pancreatic duct, whether putting a pancreatic stent will help. This was a study that came again from Europe, where they use these stents for acute pancreatitis, pancreatic leaks. And this study, 100% of patients who had a stent got infected, whereas only 50% of the patients who didn't have a stent got infected, which means we should not be doing stenting for pancreatic leaks in acute pancreatitis. This is very clear. So the only indication is removal of the stones in the CBD. We should not be doing any other procedures in this patient. So this is my last slide to conclude that if you have a patient with acute gallstone pancreatitis, you have to be very clear when to do an ERCP. ERCP should be done in these patients only when there's associated cholangitis. Gallstone pancreatitis can be predicted mild or predicted severe, whatever it is. It has only if there's cholangitis, you must do ERCP. And this ERCP should be done within 48 hours. And this ERCP, preferably if you have this facility in your department of endoscopic ultrasound, should be done after endoscopic ultrasound. So gallstone pancreatitis, acute cholangitis, do an EUS, and if EUS is positive, do an early ERCP within 40. So this should be what we should do. Patients who do not have cholangitis, only conservative treatment. There should not be any intervention. In patients who have no cholangitis, but endoscopic ultrasound shows CBD stones, if there's a progressive pancreatitis or progressive cholestasis, you can do a therapeutic ERCP, but not urgent. You can plan it carefully and do it. But no obstruction on EUS, we only do conservative treatment. So this in summary is what is the current evidence, standard of care for patients with ERCP in acute pancreatitis. Again, I like to emphasize here that the only indication for intervention in acute gallstone pancreatitis or any form of acute pancreatitis for ERCP is acute cholangitis. And only then these patients will have some benefit by intervention. Thank you very much.
Thank you, sir, for your excellent presentation, sir. We have a few questions. When we suspect, sir, acute biliary pancreatitis in case of negative imaging, sir, particularly in Bangladesh, most of the centers don't have US.
So if you have acute gallstone pancreatitis, you suspected gallstone pancreatitis, the way to suspect it is, of course, ultrasound will show gallbladder stones. Ultrasound does not pick up CBD stones because they're small, because these patients have gaseous distension and the CBD may not be dilated. So in that such situation, we rely on LFTs. In LFTs, the abnormality will be in SGOT, SGPT. Both SGOT, SGPT will increase. Bilirubin rise will be very small, usually 2 or 3. But SGOT, SGPT will be 200, 300. That is when we should suspect that these patients have. You can do an MRCP, but the problem with MRCP is that usually small stones less than 6 millimeters are not detected. These patients have difficulty in holding breath, so you don't get a proper MRCP pictures. And of course, transporting this patient to the MRCP room and all is not so easy. So therefore, it is not very common. And so my opinion, people who don't have the facilities for US in Bangladesh, if you have to suspect it, if you have a patient with acute pancreatitis, an ultrasound shows gallstones in the gallbladder, look at the LFT carefully. LFT shows an abnormal SGOT, SGPT. And there is, of course, leukocytosis, which can occur in pancreatitis also, but leukocytosis is there. Mild elevation in bilirubin, then you can go directly for ERCP. But if you have facilities for US, kindly do endoscopic ultrasound.
Thank you, sir. Another question, sir, regarding splenectomy in idiopathic recurrent acute pancreatitis. Sir, it is beneficial?
No, splenectomy is not beneficial in recurrent pancreatitis unless there is some reason. For example, there are many causes for acute recurrent pancreatitis. The causes where sphincterotomy will benefit is in those with papillary stenosis, pancreas divisum, those with choledochoseals, and those with parasitic infection. These are the 4 indications for sphincterotomy. In others, we should not do sphincterotomy.
So in case of sphincter body dysfunction, is there any role of ERCP?
Yeah, so sphincter body dysfunction actually is an American disease. We find very rarely in our countries. I think it was actually very exaggerated in American literature, but even now they have stopped doing in these cases. Very small indication is sphincter body dysfunction type 1, where you have a dilated CBD, sometimes dilated pancreatic ducts, abnormal LFT. In this case, a sphincterotomy is helpful. But if you have a sphincter body dysfunction type 3, we should never do a sphincterotomy. This has been very clearly shown in the episode trial by Peter Cott.
Thank you, sir. Sir, another question regarding patient having the gallstone as well as the choledocholitis. After clearing of the CVD in case of acute biliary pancreatitis, could you put biliary stent if we do same day cholecystectomy?
Yeah. So this is a very good point. Many people want to put a stent after clearing the CBD, especially they do that cholecystectomy is delayed. So now we have a very nice study which came, which was published in Lancet years back. We showed that if you have a patient with gallstone pancreatitis, you clear the CBD, and if you wait later than 4 weeks, the chance of recurrent cholangitis increases because the stone slips down. So if you're going to wait more than 4 weeks, then you can put a stent. But if it is going to be before 4 weeks, in India and Bangladesh, usually they go for a early cholecystectomy, then no need of putting a stent. The only indication for a stent is this situation is one, if you're not clear whether you're cleared the CBD, there's some doubt that some sludge is remaining, some stones are remaining not cleared. One. And second, if there's a very abnormal anatomy and you want to help the surgeon that you should not injure the CBD. So when you do an ERCP, you find, for example, that the right hepatic duct is very close to cystic duct, is entering to cystic duct or something. So surgeon can mistakenly clip that. So to help him for that, we put a stent. These are the 2 indications only. Otherwise, if you're doing early cholecystectomy, no need of putting it.
Yes, sir. Sir, thank you for your excellent presentation once again. Welcome you all. Welcome you again, sir. Thank you, sir.
So we're looking
Yeah.
forward to Dr. Farooq's lecture, and after that, we have live demo.
So we now we are moving to next lecture by our eminent professor, teacher, and Professor Farooq Ahmed, sir, and his topic on risk assessment and reduction in ERCP. Sir, over to you, sir, for your talk.
ফারুক স্যার, আপনার প্রেজেন্টেশন নিচে যে প্রেজেন্টেশনটা আছে ওইটাকে ওপেন করেন স্যার। নিচে দেখেন পাওয়ার পয়েন্ট যেটা আছে, পাওয়ার পয়েন্ট ফাইলটা ওপেন করেন স্যার। হ্যাঁ, এটা 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 স্যার ওপেন করেন। এখন স্যার ফুল স্ক্রিন মোড দেন, তাহলে শুরু করতে পারবেন।
স্যার দেখা যাচ্ছে, স্যার।
আনমিউট করে নিয়েন স্যার, আপনার মিউট আছে।
Can you hear me now?
Yes, we can hear.
Thank you. So sorry for undue delay because of some problem with net. First of all, I want to tell one thing that talking on a topic of ERCP in front of Professor Reddy, who is the new father of ERCP. So I am begging my pardon and apology to Professor Reddy because I will talk on a topic for which you are the topmost master in the world. So I will talk on ERCP, the risk assessment and reduction. And I will start with a statement of Confucius. You know that he is a Chinese philosopher, and his statement was, study the past if you would define the future. So if you want to have anything new, you have to study the past. And development of new things starts from where there is dissatisfaction with the way the things are. ERCP was first reported by McEwen in 1968, and from then onward, it has evolved into a therapeutic procedure from diagnostic one, and with time, it has evolved from therapeutic to advanced therapeutic and to a final therapeutic procedure time over the last couple of decades. And there are a lot of complications accompanied by ERCP, of which EP is one, post-ERCP pancreatitis. I will not talk on this one because this has been spoken on the very first day of this session. So other complications are bleeding, perforation, infection, cardiopulmonary problems, etc. And it varies from case to case. And this is a major study reported from Italy, major study comprising of showing major complications from diagnostic and therapeutic ERCP. And this was a multi-centric study, and they have reported 2,769 consecutive patients from different hospitals over a period of 2 years. And in their study, they have shown all the major complications in addition to minor one also. And you see the list of complications here are pancreatitis, mild to moderate to severe event, cholangitis, hemorrhage, duodenal perforation, retroperitoneal perforation, and other complications like cardiac arrhythmia, basket tripping, acute cholecystitis, and pneumothorax, even duodenal papilla hematoma. So these are the list of complications that may happen with any source of ERCP, particularly both in diagnostic and therapeutic ERCP, and particularly therapeutic ERCP. Now ERCP, why there will be complications, and what are the factors determining this, the happening of these complications, or factors influence the safety of this procedure. So first one is what? What means, what is the procedure you are doing? Is it diagnostic or is it therapeutic? Next one is, what is the sedation you are using and what is the level of your monitoring? So these are the things which may influence the safety or influence the development of complications with ERCP. And second W is who is doing the ERCP. So the doctor who is doing the ERCP, that is a factor influencing the safety or the risk of ERCP. And who is the patient? So selection of patient is also very vital to determine the safety and also the complication. And next W is why you are doing the ERCP. So the indications and contraindications should be justified very meticulously. And third one, and one of the most important factor is where you are doing this ERCP. Whether you are doing the ERCP in a new center or a low volume center, or you are doing the ERCP in a high volume center. And regarding the risk factor, few risk factors, as I was telling, who is dealing with the ERCP. Of the two, one is patient. So there are factors, few factors related to the patient. And these are the list of factors related to the patient which may influence the safety of ERCP or the risk of ERCP. Number one is normal. If you do ERCP in a patient with normal bile duct, definitely that is a high risk patient. And a young patient is also high risk. Female patient having history of recurrent acute pancreatitis or history of post-ERCP pancreatitis in the past, and patient with normal serum bilirubin level, and also patient with SOD is also a group of patients who are at risk of developing ERCP complications. And these are other factors which may also influence the safety, which includes duct infection. If any patient has got cholangitis, that is a high risk group, and patients who are undergoing endoscopic sphincterotomy, definitely these are the groups who will be landed with more complications. Particularly pancreatic sphincterotomy are the groups of people who will be landed with more complications. Patients with balloon dilatation who need balloon dilatation for their therapeutic purpose, they will also have more complications in the group. And definitely this group of patients who will have difficult calculation or who will have pre-cut, they will have more complications than other patients. And these are the risk factor that will be related with the physicians who are doing this procedure. So this is the endoscopist, ERCPist related risk factor. So if anybody is a trainee, or if anybody is not using guide or not using pancreatic duct stent in high risk group who are high risk for development of post-ERCP pancreatitis. So if anybody is not using this pancreatic duct stent, they will have more complications. And this is another study showing, showing from Italy. That is a study published in intestinal endoscopy back in 1998. That was a first very large reported prospective study from multicentric study from Italy. They have included 2,769 patients, showing the comparison between different types of different factors that may influence the complications of ERCP. And you see, in first one is significant multivariate analysis. So small center and PCAT, these two was showing to be a most important risk factor for development of post-ERCP complications. And also the intramural injection, repeated ERCP, and the electric current that we are using, there is also a factor influencing these complications. And small bile duct means bile duct, if it is not dilated, in that case, the complication. So these are the important risk factors associated with the development of complications in ERCP. And this is another table showing significant risk factor for specific complications. This also includes small bile duct. Age is also important factor showing here. So advanced age will be accompanied with more complications. And if you pacify pancreatic duct repeatedly or with excessive diet, that may also lead to complications. And small volume center definitely is a very important risk factor for development of complications. If anybody has cholangitis, anybody has got hemorrhage during this procedure, then they will have more complications than comparing with the other groups of patients. And this is also a very important table showing the comparison between small center and large center. So if anybody has ERCP in a small volume center or ERCP in a large volume center, that have a tremendous impact on development of complications with ERCP. So small volume center, if we compare with large volume center, you see most of the factors are significant. So even if you do this procedure in a small volume center, that case you may have more complications than if you do it in a large volume center. So these are very important things we have to remember, that Large volume center means who are doing the ERCP regularly, ERCP in large volume of patients. They will be definitely a good performer and safety. They will have more safety with this procedure. And this is another study published in Gastroenterology, and they are showing the rate of complications with biliary cannulation. So biliary cannulation success appears influenced by both patient and practitioner factor. But the most important factor, or there are a lot of factors influencing this thing, but most important factor is the volume influences ultimate success. So volume is the most important factor predicting the success and predicting the complications rate. So volume is the most important factor in, if you consider the complications in ERCP. Now I'll discuss on a few complications, few important complications. For example, the bleeding first. So bleeding is a serious adverse event in ERCP, and it most commonly occurs in endoscopic sphincterotomy. And other causes of bleeding other than sphincterotomy are splenic injury during ERCP, hepatic injury during ERCP, vascular injury, and also hemophilia. For example, during biopsy or with other interventions in the biliary tree. So these are the factors which may be related with bleeding in ERCP. And bleeding may be immediate or may be delayed. Immediate means during or immediately after the procedure, or it may even occur hours to several weeks after this procedure. And the bleeding may be mild, moderate, or severe. This is a classification done by Peter Cotton. And this mild bleeding is clinically, only you see it in clinically, and hemoglobin drop will be less than 3 grams per dl, and there will be no need of transfusion. But if anybody needs less than 4 units of transfusion, but needs no surgery or intervention, he will be labeled as moderate. But on the contrary, if anybody needs transfusion more than 5 units or needs any intervention, including surgery, they will be labeled as severe. And fortunately, in most of the cases, the bleeding is mild to moderate, and severe bleeding is not so frequent. So risk factor for complications of ERCP also shown in a study from USA, and it was published in Gastrointestinal Endoscopy. And you see among the author, Peter Cotton was with them. So they also shows the frequency and severity of complications in painkiller in different ERCP. And they have shown that bleeding is one of the important complications in this series. And fortunately, in most of the bleeding was mild to moderate, but severe bleeding or fatal bleeding was less. And risk factor for complications after ERCP was shown in another multivariate analysis on more than 11,000 patients over 12 years. That also been published from USA, and Peter Cotton was with them. So they have shown the predictor of post-ERCP bleeding. You see among the predictors, age, race, sex, even the procedural like biliary sphincterotomy, pancreatic sphincterotomy was the factor responsible for bleeding. And this is another study showing the bleeding rate in ERCP, and fortunately, severe and fatal bleeding rate was also less in this series. And these are the factors responsible for development of bleeding. For example, there are a lot of factors you see is related to the bleeding: coagulopathy, cirrhosis, or cholangitis, tumor in the ampullary region are the factors among a lot of factors. These are the factors mostly responsible for bleeding. So bleeding in ERCP is mainly a concern of endoscopic sphincterotomy. And sphincterotomy definitely is an independent predictor of bleeding. And performance in low volume center is another important factor for bleeding, even in patients with EST. So in low volume center, definitely the endoscopic spectra, inuit expertise specters, and electrosurgical or accessories that has been used are also responsible for development of more complications in low volume center. And definitely those who are having endoscopic sphincterotomy, oculopathy is also a very important factor. And resumption of anticoagulant after the end of the procedure is also a very important factor in development of post-ERCP bleeding. And cholangitis is also very important factor because of in cholangitis there are basically edema and friability of the tissue that will be responsible for development of bleeding in patients with cholangitis. And low volume center is coming once again. Low volume center is always a risk factor for development of all sorts of post-ERCP complications, including bleeding. And bleeding during procedure is also a factor that will also be accompanied with delayed bleeding. And regarding anticoagulant or antiplatelet agent, definitely these are important risk factors for development of bleeding. But fortunately, antiplatelet agent, if you use as a single agent, do not increase the risk. And this is also been shown in different studies, and most of the studies show that these antiplatelet drugs do not show increased risk either with aspirin or with non-aspirin agent. So single agent, if you use single agent, in that case the risk is supposed to be not higher. And as I was telling that in most of the cases of bleeding, the bleeding is usually mild to moderate, and most of the cases of bleeding are self-limiting and successfully managed by ERs during endoscopy, during ERCP. So to reduce the risk of bleeding, perform the ERCP as safely as possible. And you have to understand the patient and procedural risk factor, and careful assessment before ERCP is also very important. And now I'll show you another complications, that is perforation. Perforation is one of the important complications related with ERCP. And this is shown by different studies. As I have already mentioned, that there are few landmark studies related to ERCP, and all these studies show that perforation is the important complications of ERCP. And although perforation may occur in low number of cases, small number of cases, but perforation is definitely a very risk factor. And in some cases, perforation may be accompanied with even fatal complications and even mortality. So although perforation is rare, but there are 4 types of perforation which may happen in ERCP. Number 1 is duodenal wall perforation, that is easily done by duodenoscope. So perforation done with duodenoscope that is perforation of the duodenal wall. And second one is periampullary perforation of the medial wall of the duodenum due to endoscopic sphincterotomy or precap. Bile or pituitary duct injury caused by guiding or stenting is another types of perforation. And the next one is retroperitoneal resulting from excessive insufflation together with sphincter perforation. These are the types of perforation that may occur with ERCP. And the main 2 types of perforation is scope-induced, that is duodenal wall perforation, and second one is accessory-induced perforation. So duodenal wall perforation done by the scope is big hole. There is big perforation, and accessory-induced perforations are small hole perforation. So duodenal wall perforation easily occurs when scope length is a long scope with long scope length, and if the anatomy is altered, tortuous anatomy, or if there is any adhesion in surrounding structures. And accessory-induced perforation occurs more with precut, more with intramural contrast injection, and with biopsy or ablation. If you do ablation, in any case, that will be blended with ERCP perforation. So these are the 2 main types of perforation, and to minimize this perforation, we can go for some precautionary measures. For example, to avoid big hole perforation, one has to avoid excess manipulation in the duodenum. So if you go for excessive manipulation in the duodenum, when the scope is in the duodenum, so that is a very high risk factor for big hole perforation. And to avoid this one, you have to avoid excessive manipulation. And in cases where there is altered anatomy, in those cases you can use EOS or direct transgastric ERCP. So these are the measures which you have to adopt to reduce these complications of big hole perforation by the scope. And excessive induced perforation, although it is well tolerated, but one has to avoid these sorts of complications. So to avoid all these complications of big hole or small hole perforation, you have to take care during pre-cut or during even endoscopic sphincterectomy conventional, and you have to know when to stop. So when to stop is very important factor related to prevention of complications with ERCP. And definitely informed consent is very important factor in these cases, at least for medical legal reason. Because if you go for proper informed consent, that will be definitely important factor for safety purpose. And regarding management of perforation, number one is if anybody unfortunately has got duodenal wall perforation, definitely that will be managed mostly by surgery and in some cases may be possible endoscopically. So duodenal perforation mostly needs surgery, and in some cases maybe, if fortunately, they may be managed with endoscope. And periampullar perforation easily managed endoscopically, and you can avoid this one if you limit the length of cutting wire in contact with the tissue, and if you go for stepwise cutting, that will be helpful for prevention of development of complications, that is small perforation. And placement of a self-expandable metallic stent will be helpful for managing this sorts of perforation. And so this is the main step for management of periampullar perforation by excessive induced perforation. So nasopelvic decompression is another way, and nasoduodenal decompression is another way, and placement of endoclip is another way to manage this small hole perforation. So this small hole perforation is mostly managed endoscopically, in contrast to large hole perforation, there is duodenal wall perforation, which in most of the cases needs surgery. And the other sorts of perforation also could be managed endoscopically. So placement of, in endoscopic management, placement of stent is the most important option for management of perforation. There is small hole perforation. And there are few cases of rare cases of stent-induced perforation, and this occurs particularly result from migration of plastic or metal stent. And no particular stent is of higher risk. So both risk is equal with both plastic and metal stent. And endoscopic removal and endoscopic closure is the mainstay of management of this sort of perforation. But if anybody develops peritonitis or retroperitoneal collection, in that case, he may need surgery. So although these sorts of perforation is very rare, but most of the cases can be managed endoscopically, but some unfortunate case may need surgery. Now I'll tell few more complications which we have to take care, and this is related to radiology. And you see, during ERCP, we have to use X-ray machine for fluoroscope, and X-ray is very important risk factor for the healthcare personnel and also the patient who are dealing with ERCP. So this is an important paper publication from Peter Corton, which reveals a multinational quality network which records the fluoroscopy type during ERCP. And in this paper, they stated that the optimum time should be within 10 minutes and 40 minutes is the highest limit. Before after more than 40 minutes is definitely very high exposure for radiology. And they have shown that that there are few factors that may be responsible, that may be accompanied with higher radiological exposure. For example, a higher lifetime ERCP experience. That is those who are doing large volume ERCP and lower difficulty grade. So if the case is not a complex case, simple case, that will be accompanied with low radiological exposure. And definitely in academic institutes where trainees are involved and various therapeutic procedure, pain calculation will have higher fluoroscopy time. So these are the important factors related to fluoroscopy exposure, and presence of experienced X-ray technician may help to lower this time. And there are a few other steps which may help to lower this radiological exposure, which includes experience of the endoscopist and also the other stuff related to the to ERCP. And awareness is another important factor related to reduce the radiological exposure. And definitely lowering the failure rate, that is experience of the endoscopist, ERCPist is very important factor for lowering this radiological exposure in some cases. And I think I have lost few slides, and there are few slides regarding the drug side effects. I'm not going to tell these things, but because these drug-related side effects are also very common if you consider the complications of ERCP. So of these drug-related complications, definitely allergy to different drugs used during ERCP is important. Particularly, we are using contrast. So contrast use is may be accompanied with allergies. So to manage this issue, we have to be careful in managing this thing. So finally, I want to tell few things that ERCP, although is an excellent therapeutic procedure right now, but it is accompanied with few complications. So to avoid these complications, we have to be very careful. Number one, we have to select appropriate cases, and you have to judge very critically regarding ERCP. If you do have any alternative, any safe alternative to ERCP, definitely we have to opt for that one. So critical appraisal of the cases, critical appraisal of the indications, critical appraisal of the procedure which you are going to do is very important factor to prevent complication, to make this procedure very safe. So we have to keep these factors in mind. So that's all from my side. Thank you, everybody.
Thank you, sir, for your excellent presentation. Sir, we have few questions. One question is from Sukanta Das. Sometimes it is very difficult to differentiate between cholangitis and complicated pancreatitis and gallstone pancreatitis. What to do in these situations?
I think this is question for me or for Professor Reddy.
Anybody, sir.
Can you repeat it again?
Yes, sir. It is this question from Dr. Sukanta Das. Sometimes it's very difficult to differentiate between cholangitis and complicated pancreatitis in gallstone pancreatitis. What do you do in this situation, sir?
I think this issue has been addressed by Professor Reddy. In acute pancreatitis, the thing is very clear when you will go for ERCP and when you will not go for ERCP. So first of all, you have to assess your case, whether he actually needs ERCP or not. And complicated pancreatitis and cholangitis, I think there are a few criteria by which you can differentiate between these two. And the implication of ERCP in both the issues is separate, and indications is separate, and definitely you have to be very careful in doing ERCP. Although it is very effective procedure in treatment of some cases of acute pancreatitis and cases of acute cholangitis, but still it is not universally recommended to do this ERCP in all cases. So you have to judge, you have to assess the cases as has been already spoken by Professor Reddy.
Another questions to Reddy sir from Tohit Mojumdar sir. And what is the role of emergency laparoscopy cholecystectomy in cholesterol? Reddy sir not able to. Reddy sir.
Can you repeat this question? We can try to answer it.
Okay, sir. This question from our Tohit sir. And what is the role of emergency laparoscopic cholecystectomy in gallstone pancreatitis?
You see, in gallstone pancreatitis, regarding surgery of the gallbladder, there are few scenario here. If anybody has got mild acute pancreatitis, you have to do gallbladder surgery at the index admission. So that surgery can be done, mostly will be done by laparoscopy. So in cases of mild acute biliary pancreatitis, one has to remove the gallbladder at the index admission. But if anybody has got severe or moderately severe acute pancreatitis or pancreatitis with complications, in that cases you have to wait. It is safe to wait. So you have to control the sepsis, you have to control the complications. Then you go for surgery for the gallbladder. So in those two cases, surgery at the index admission is not usually recommended. So emergency removal of gallbladder is not indicated in most of the cases.
Another questions from Urdu Prakash. Sometimes some patient admitted in hospital lately after 4 days with acute pancreatitis with cholangitis. Is emergency RCP is indicated then after 4 days?
Emergency RCP in acute biliary pancreatitis, it has been addressed by Professor Reddy. You see, in biliary pancreatitis, if anybody has got associated proven cholangitis and if has got a documented shown in the CBD, in that case you have to go for emergency endos ERCP. Otherwise, emergency and ERCP is not indicated in biliary pancreatitis.
Another question from Dr. Naimul Hassan. What do you mean by the high volume center? That is, how many RCP per day or per week should be performed to tell it that this is the high volume center?
It's there is variation in the number, but on an average, if anybody is doing at least one ERCP per day, or if a center is doing more than 250 or 300 ERCP in a year, that will be labeled as high volume center. But the number varies from center to center, country to country.
Another question from Rehan Habib. How we can differentiate post ERCP cholangitis and from pre-ERCP cholangitis?
Definitely, if you want to do ERCP in a case, before going to do ERCP, you have to assess what is the problem with the patient. Definitely, before doing ERCP, if anybody has the cholangitis, he will have a history such of cholangitis, and there might have lab data along with you that will help you to diagnose that he has got cholangitis. Whatever it is, you have to diagnose this case prior to ERCP. So cholangitis before ERCP, cholangitis after ERCP, I think it will be not difficult to differentiate.
Another question from our Olograha side and from CMCH. Is there any influence regarding safety to reuse of accessories during RCP? The reuse of
This is very important issue for people like us due to some economic constraint. So reuse of accessories is not easily entertained, but we have to do it in centers like us. So it is better if you could afford disposable accessories, but if you cannot afford, in that case, we can reuse. There is some accessories which are reusable. So I think we can go for it, but definitely, ideally, we should go for disposable accessories, one-time use accessories.
Another question, sir, regarding pre-cut, sir. In case of pre-cut, to minimize the risks of bleeding or perforation, should you do above downwards or below upwards?
Number one is PCAT is not always entertained. So one has to target for conventional peptidotomy. And if you do PCAT, both the system is there. So somebody may do it from below upward, somebody may do it from above downward. I think if Reddy sir is with us, he will address this issue in more detail. So I think first of all, you have to try for conventional peptidotomy. If it is not possible, if you are bound to go for pre-cut, in that case, you can go in both the way. But mind it, pre-cut should be done with utmost care. Whatever pre-cut below upward or above downward, but you have to be very careful. You have to go by stepwise. You have to go layer by layer so that complications rate will be.
Thank you, sir. This is the last question, sir. We got a few patients with biliary sclerosis with pregnancy, sir. And in that case, how sometimes patient came to us during first trimester or second trimester or third trimester, any time. So how we can reduce the risk during RCP of that patient?
Any radiological procedure in pregnancy is we have to try to avoid. So you have to go for ERCP in a pregnant lady when it is really needed and it is life-saving. So in that case, there is some system to do it safely, to say which will make safe it for the mother and also for the baby. So if she need it, if it is really needed for her, in that cases we can do it.
Sir, should we move for live workshop, sir? No questions, sir.
I think we can go for that. Mohsin, you can ask people from AIG. Maybe Shakto is with us. He will help us.
Okay,
And,
we're waiting. Thank you.
yeah. Hello. Yes, sir. Sir, you are live. Dr. Rakesh. So, good to see you too. So this is
device looks externally so that you'll get a hang on of what I'm doing. So this is the device, how it looks externally. It's got a handle which you hold like this, and then there are few markers on this. I'll explain you. And this has got a 16 mm thickness with a distance. And can you show it to you? Yeah. This is the helix used to get the tissue. And if you see the handle, yeah, or the switcher, and also a shaft which will, just like an endoscope, you can retrovert the device as you see here. Can you appreciate that motion? So this is how it looks, and then you can again flex it back into normal position. So this is the device which you can see externally, and for want of time I have already deployed it, and I have Dr. Herman who is giving me the anesthesia help under GA, and I have Asif who is my second operator. Another important thing what I want to show you, this device has got a channel through which a pediatric scope goes inside, and then this scope is used to guide as the third eye. So Dr. Asif has put the scope for me to the pediatric 6.5 mm scope, which has gone through a channel, and then he is showing me how it looks on the endoscopic view. And Srinivas is catching a sphygmomanometer cuff. This is used to inflate so that I will get enough room on the endoscopic screen to see what I am doing. So now going to the first step, what I will do is I will open the eagle class which is showed externally, and I will see the device is retroflexed, endoscope is retroflexed, and we typically take people who have HINS grade 1 or 2. So in that we usually end up deploying 2 switches. So what I am doing now is I am going to go open both the eagle class and then turn towards the extreme left side so that I will be covering most of the graphic curvature. So as you see on the endoscopic screen, I have locked myself, and then can you turn to the other side? Yeah. So I'm pushing the helix outside. Can you see the muscle? So once the helix is outside, I will make 3 to 4 rotations so that I will grab the mucosa and then take the mucosa inside. Once the mucosa is inside the helix, grabbed inside the helix, Srinivas has closed the helix, and now what I am going to do is I will position myself so that I will get big chunk of tissue, and then from this open mode, I will go to the closed mode so that I can close the eagle class and get a good chunk of tissue. So once I get a good chunk of tissue, I will reascertain myself where I am in a proper position. So I am in, so now I will go to the fire mode. So once I go to the fire mode, there is a lever here which you just have to gently press twice. The best part of this is once you press twice, it will be locked. After that, you won't have the pressing effect. So what I am doing is 1, 2. So that's it. So that means the suture is deployed. Now I don't have to do anything in this. I'll go back to the step 1 what I started. I will unlock the helix and then unwind the helix so that it will leave the mucosa and it will, helix is taken inside the device. So once I unlock the helix and then the helix is inside, I will go back to the open mode and then open the jaws. Can you see it there? So I'll just give a little downward touch so that the device is free. Now I will, under vision, go back to the close mode and then close the eagle claws. Can you see it here? So now can you show the fluoro? Asif will straighten the pediatric scope under fluoro and then he will take out the scope. Along with him, I will take out the device to deploy the second suture. So now we will show you how the second suture is deployed and how we will load it. So once the first suture is deployed, the second suture should be typically towards a lesser curvature where we will cover almost 3/4 of the circumference, and this is a gastric fundoplication, unlike the laparoscopic fundoplication where they do esophagogastric. So the difference between a typical Nissen fundoplication and this is gastrogastric. So I am going to start from step 1 so that you have more clarity on how I load the suture and how I mount the scope into. So let me start with the process, the step 1, where I have taken upper GI scope, which you haven't seen in the last few minutes. I've taken a typical simple upper GI scope and I'm going to intubate the patient and go inside. So once I go inside and intubate the patient, I will also show you how the first suture has been deployed. Can you appreciate there, Mosin? You see here the suture is a transmural suture, through and through. Can you see it? Yeah. So now what I'm going to do is I'm going to go into the pylorus and then the first part of duodenum. Then there is an inbuilt metallic guide wire what we use for dilating the salvagelar dilators and all. So this comes with the device. I will put this metallic guide wire into the upper GI scope and then leave it in the first part of duodenum and pull out my upper GI scope. So the wire will be in situ and the upper GI scope is out. On this metallic wire, I will railroad the Verdex device. I will show you how it is done. So the device is externally shown before and our technicians are putting the suture. Because can you focus here? So what I am doing is I am pushing this guide wire, metallic guide wire into the device. You can just show them here. How much in this too? Yeah. So as you see here, the device is railroaded onto the guide wire. Yes, sir. Okay. And then once the guide wire comes out through the external channel on the other end, I will intubate it, and as you see here, one more important point is this should be parallel to the ground, and we usually apply silicone gel as a lubricant instead of dilatant. And if you can focus on the patient's mouth, so the patient is on the GA, and as you see here, I am applying little press on, and Hernad is helping me to flex the jaw. As you see here, under fluoroscopy, you can see a smooth driving of this device into the stomach shadow and the gastric shadow. So once it is there inside, what Srinivas is doing is putting in the sphygmomanometer cuff and then trying to inflate. And now Dr. Asif will irrigate the channel where the scope is going to be there, and then we will put the pediatric scope. We use the Olympus scope for this device, pediatric Olympus scope. So as you can see, Asif is putting in the scope. Yeah, please push it inside. So this scope acts as a third eye and guides me what I am doing. So once the scope is pushed beyond into the mucosa, as you see on the screen, yeah, push it please. You can take the fluoro guidance also just to see that the scope is inside. Now, once the scope is inside, you can see the tip of the device is seen. Can you appreciate? So what me and Asif will do is we will collectively retroflex me the device and Asif the scope, and then we will be guiding me to show where I am going. As you see here, he retroflexed, I retroflexed, and now you can see the first suture being deployed, the second suture, what I'm going to do now is take the mucosa towards the lesser curvature. So I'm going to redo again the same steps, open the jaws and then go towards the mucosa, towards G junction, and I will first lock so that I will be in a better position to hold what I'm doing. Now I will just go a little bit nearer to. As you see here, one more important point here is we have this cramo-columnar junction, the pinkish mucosa. You make sure that the second suture is not deployed on the pinkish mucosa, because there is a little bit of side effect in this where if the suture touches the pinkish mucosa, there will be little diaphragmatic irritation with left pleurisy, which we very rarely see in some patients, which also is subsiding. It's not a major issue to worry about. So as you see here, can you just show me the other side as if my helix is out, and then I can see where the helix is. Can you see the helix there? It's just come out, right? So I am going to push the helix inside and then rotate 2 or 3 times so that I grab the mucosa right. Okay, so now he has locked the helix so that it will stay there, and now I will go to the closed position and close the jaws and then see, can you see? Now the whole chunk of the mucosa is coming inside, right? Yeah, see. So now it's almost a very tight G junction. So now that I am in a position where I could see that the G junction is completely embedded inside with the mucosa totally into the big claws, I'll again go to the third step which I have shown, that is firing. See, I fired it, and now the firing is done. Go back to the open position, unlock the helix.
That is the position of the patient.
Patient is in supine motion and he is intubated under GA. And our anesthetist has given a nasal intubation. So, because we will get a good amount of room for the thick device to get into the mouth. So you see here, I have deployed the second suture also.
Yeah.
So what I do is I'll again close and then take out the device along with the pediatric scope. Can you take it out? And then just show you how it looks with the upper GI scope. In the meantime, we can have some questions before they change the upper GI scope. Much anything from you?
Sir? Yes, sir. This instrument is reusable, sir.
We will see what happened initially when the company fellow started. We started giving us 2 sutures. After that, there was a request from some couple of people across the world, and now we started giving 4 sutures. So what we are doing is, it's not company specific to sterilize, but we can redo it. Suppose there are some financial constraints for any patient, but ideally it is a single-use device. What has been suggested by the company.
But in the long run, is there any development of stricture at this site?
Development of Development of
the stricture, any stricture later on?
No, because see, that's a very good question. Since we are not doing the esophagogastric fundoplication, we are doing only gastric. So the chance of suture is 0%, the stricture is 0%, there is no chance. So you see here, I put the upper GI scope and I am showing you, see how tight the sphincter has become. It just looks like a fundoplication wrap to what surgeons do. Correct?
Yes.
So this is how it looks. And you see here there are 2 sutures which are very clearly seen, the bluish ones 1 and 2, and the other part of the thing is transmural on this side. So this is how it typically looks. So once this is done, the patient will be out of extreme narrowing due to suture immediately. No, there is no narrowing. That's what I'm saying. Because the sphincter per se won't get narrowed, as this is a gastric fundoplication. We are not touching the esophageal part. Yeah. So that's the end of the procedure. We will be happy to answer if any questions are there.
Sir, is there any risk of bleeding, sir?
No. So far we have around 100+ case experience. There is no bleeding tendency unless and until the patient is on any antiplatelets, but absolutely 0% hemorrhage complications. The only side effect of what? Sorry, Mosi?
So this patient having his classification grade 2 hyperthermia.
Yes.
This guard is also applicable in grade 4 or grade 3 hydathernia in case of chart, sir.
Yeah, grade 3 Hills is intermittent where if you can afford to put 3 switches, it can be done. Otherwise, ideal case is Hills grade 1 and grade 2. They have the best response. We recently had a randomized control trial, which is due for publication, where we had 1 year follow-up, and we found around 60 to 70% improvement in quality of life of the patient, as well as 30 to 40% PPA independency with improvement in the volume reflex episodes also. So that's a 1 year data what we have as a hands-on experience.
Thank you, Dr. Rakesh. That was an excellent demonstration of the latest technology. We go to the next one. The clinical history of the patient is she is a middle-aged female with history of bleeding for rectal and intermittent abdominal pain. On evaluation, the hemoglobin was 10.4, microcytic hypotonic anemia with video colonoscopy showing a sigmoid colon polyp. The plan is colonoscopy with polypectomy, which will be done by Dr. Mohan Ramchandani. Over to you, sir.
Hello. Good morning. How are you?
Yes, sir, fine, sir. Good to see you, sir.
So this is a case of a large polyp, approximately 5 centimeter in size, in the sigmoid colon, and quickly we will do the narrowband imaging to see what type of polyp it is. So if you quickly see that there is a nice classification which tells us whether it is adenomatous polyp or it's a hyperplastic polyp. So first thing which we should see is the color of the mucosa. To compare with the right side, the normal colonic mucosa, this looks very dark. So the color CVS, you have to remember, color is for the color of the polyp, whether it is darker than surrounding or not. So it is darker than surrounding. The second is V for vascular pattern, and you can see this dark things there. These are also regular. So if you can see, I am switching between white light and NBI, and we can clearly see that the color of the polyp is darker, the vascular pattern is regular, and the surface pattern, the third thing, CVS, S is for surface. You have to see the surface there, and you can see there is a gyriform surface pattern. These are not dot-like, which are clearly seen in hyperplastic polyps. So you have to watch this very carefully, and then you can see the surface of the polyp is a gyriform pattern, which is seen in adenomatous polyp. So this looks like to be adenomatous polyp, but I can't see any area of irregularity or any invasion there. Then second thing which we have to do is to see the Paris classification. Now we can see this, all the polyps which are limited to mucosa, they are superficial polyps, and they should be classified according to the Paris classification. So the Paris classification says this is polyps, and whether when the polyp comes, then it is known as type 1 polyp. We have to see whether there is a pedicle or not. So I can see a very no pedicle, it is sessile polyp, so it becomes 1S. This is not a flat polyp, this is polypoidal mass, which is adenomatous. Paris classification is 1S. Why it is important to do the Paris classification? Because submucosal invasion depends on the Paris classification also. If this is a flat polyp or a depressed type 3 polyp, the submucosal invasion is very high. So we prefer to do ESD in that. But in this polyp, which is sessile polyp, but it is large polypoidal, 1S type, we can still do a good EMR. So first thing which you need to do is to define the base of the polyp, which we can see here, the base of the polyp is well defined, and then I will inject some saline at the base to elevate it. So I am injecting here, can you inject please? You can see now I am define the base of the polyp, and I am injecting and elevating it. You can see that the polyp is getting elevated from its base. So if we use quattrine, it will not burn through the base and will not cause the perforation.
So now this polyp is, the size has grown, but we are more safer now. You can see the base of the polyp is well elevated. The definition of base is very nice. So even if I have not big polyp, big smear, I can do, the piecemeal resection. I'll try to bring this in one go, but there are some chances that I will do piecemeal. But even if I do piecemeal, the ultimate results are not going to change. Open. Mohsin?
Yes, sir. Is there any role of envelope before polypectomy?
Envelope polyp, yes, there is root, but I will prefer it to being in a very pedunculated polyp where pedicle is there, and then I can safely cut it. So I'll jiggle through so that I can reach around the base. So I'm trying to, wait. So I'll suck out the mucosa here, jiggle, and then I'll ask him to close. You can see now still I am not very happy. So I'll just try to come to the base here, close. You can see I'm pressing down, and then I've got it in my control. Then I'll use endocut Q. So I'm ready with clips, I'm ready with coag grasper. In case there is bleeding, I'll take care of that. So I'm using endocut Q to cut this polyp. See that? And then there is completely, the polyp has been removed. There is some base, but I can see a big vessel there, which is not a problem because I will catch it with, first of all, shall we complete this, or, okay, we'll catch this big vessel first, and then we will complete the polypectomy. You can see how big the vessel is, but don't panic. Keep the coag grasper ready with you, and you can catch this vessel very nicely, and then get rid of this bleeding. But don't allow it to come to your
There is arterial bleeding.
arterial bleeding. So I'm okay. So this is the coag grasper here. So can somebody flush the water, please? Okay. So I have to be very good in the definition of the bleeding side. So I have to quickly reposition my scope, and then I caught this vessel, and then I will pass a soft coagulation. So you have to be very precise with your aiming here. Sometimes there will be two sources because artery is cut open. Still the bleeding is going on. So here, close. Here artery is quite big now. Open.
Yes, sir.
Close. Can you increase somewhat soft coagulation, please? Okay, so that's how we control the bleeding. You can see here. Open.
Sir, soft coagulation, sir. You are applying.
Okay. So you have to be very careful about not to overdo it. Open. Don't panic. Just that is the key. Open. So you can see now how still the bleeding is going on. Okay, flush please. Flush well, flush. So whole aim is to keep on the vision of the base of the vessel. Close. You can see as soon as I'm catching it, it is stopping. That means I have caught the vessel nicely. Only thing is I have to pass the soft coagulation for a long time. And in sigmoid colon we can do that, but it is in cecum or ascending colon, the wall of the colon is very thin. But I'll make sure that I close this rent by doing the clipping after some time. So I'm just not releasing it because I have caught the vessel, but still. Okay, open now. So now the bleeding is completely stopped. Now we have one more polyp remaining there, half of the polyp. So we inject first, elevate the base, and you can see nicely there is one more vessel there, but it is of no worry to me because it is very small, and whatever the blood comes will not spoil the field. The previous vessel was quite big, and if I don't tackle it fast, it may quickly fill with the blood, and I will not be able to see anything. So now this polyp which is remaining here will inject some saline here. Inject. No, I'm not happy. So we'll go to this base. I think that's also gone almost. So I'll take the snare and cut it off. So then if we apply force coagulation, force coagulation, no, soft coagulation. Force coagulation basically is for dissection. For coagulation, you should always use soft coagulation. Open. So we'll catch this. This is small residual polyp which we'll cut it off. And you can see nice base now completely. We open the process 1 minute. Okay. So this is a small residual. No. Close. So now we got complete polyp out with no area of bleeding. So we'll now clip it because we have used a lot of coagulation there. So we'll clip this, and then if you want to see the clipping, it's okay. Otherwise, you can move to next room because we have many interesting cases coming up.
Is there any recurrence from
Sir? Thank you very much. We'll go to the next case. Mohsin, I'll take your case question once that we'll come back to next demonstration. Thank you, sir, for the excellent demonstration. We'll go to the next case. The clinical history is 44-year-old male with acute necrotizing pancreatitis and with index episode 2 months ago. Presented to us with abdominal pain, vomiting and fever. He has leukocytosis, WBC count of 18,000 with anemia. The CT is showing a large communicating wall of necrosis in the lesser curve, which is extending to the subhepatic space with multilocated ascites. The plan is EUS-guided cystogastrostomy with SEMS placement. Over to Dr. Sandeep Lattak.
Good afternoon, sir. Good afternoon, sir. Good to see you, sir. You are not audible, sir. Sandeep, sir.
Good afternoon, sir.
Sandeep, sir. Hello, Dr. Sandeep. Sir, Sandeep, sir. Sir, you are not audible, sir. Can you hear me now? Yeah. Yes, sir. Okay. Thank you, Hardik. Thank you, sir. Mohsin, can you hear me?
Good morning.
Good morning, Mohsin. I can hear you. Dr. Farooq, can you hear me?
Yes.
Good afternoon, sir.
Good afternoon. So we have the EOS image there on the screen. If the cameraman can, so you have the EOS image there, and you can see a large collection there. Can you appreciate that?
Yeah.
And if I just pull back and torque around, you'll see some kind of a honeycomb appearance.
Yeah.
Okay? So this is a loculated ascites. This is not a worm. So we have to be very sure what we are dealing with. If I puncture more, I will cause more problem. If I drain this collection from the stomach, there is a likelihood of perforation. Why I am saying this is because if I pull back, this is a collection which is in the lesser sac.
This is posterior to the stomach. The reason I am saying is that you can see the kidney posteriorly. Also, you can see the aorta here, if I can put a Doppler there on top. So this is the aorta. And these are the blood vessels which are coming from the aorta. It's SMA which is going down. So this goes behind the collection is the SMA. And there is celiac artery here with splenic artery here. So they are all big vessels in the wall of the collection on the posterior aspect. So this is what I have to drain. But you see inside it has a lot of debris. So this collection has ruptured and caused some kind of ascites, which is now you see on the left side. So this is the collection in the pre-peritoneum located ascites, and this is the one. So there are two different things. They are probably communicating with each other, but it is safer to drain the lesser size collection and not the pre-perforation. Also, if I turn around, you will get to see the liver here. So this is the left lobe of the liver, and below the left lobe is this collection with septa floating inside. Now you see the cobwebs are much more prominent. These are fibrin septa. I don't want to drain this. This is draining of the ascites from the stomach, which is a short recipe of perforation. Okay? This is that clear? Also, if I pull back, this is now the left lobe which is floating in its water. The diaphragm is here. So this is all ascites, both superior and inferior to the left lobe of the liver. And lower down we have a more located collection. This should be drained percutaneously if it continues to remain there. So let's come to the drainage of the one. So this is a large wall of necrosis, and you see debris inside. Almost 50% of it is debris and 150 is fluid, which is very ecogenic. So we'll drain it from here. Agreed? I see a child, I hear a child's voice. Maybe a young gastroenterologist from Bangladesh. Mohsen, can you hear me?
Yes, sir.
I can't hear you, Mohsen. I'm not sure whether my voice is reaching you.
Yes, sir. Yes, sir. I please, sir.
So this is the wall of the cyst which I am going to puncture. If I measure the wall, this would be about 5 millimeters or so. That's less than 3 millimeters. So I'll be using a magic stent in this patient, a metal stent. So here comes my needle. I'm looking for any blood vessel which is not there. I'll switch it off. You see the needle on top? That's the needle there, which will puncture here.
Yes.
So that's the first step. You puncture the wall of necrosis of the pancreas, aspirate the fluid out. If you can, Srinivas, you can do that. And that will show us the content. So it's a very turbid fluid, very purulent. If you can see it here. So that's the cause for this fever. Stop. Okay. Should be okay. This is sent for analysis including culture and amylase. And then I will pass a guide wire. Do you have the fluoroscopy image there as well? So that will show you how the guide wire looks like. So that's the guide wire which is coiling inside on the fluoroscopy image. That should be okay. It's not really coiling well, but that's good enough. I'll pull back the needle leaving the guide wire inside, and my arrow is pointing at the guide wire. So that's a very important mark that I will keep my guide wire always in the view as I pull back. So Srinivas is pulling back the needle while pushing in the guide wire. So the next step is to create a fistula between the stomach and the cyst cavity. Then I have a cystotome, 6-point cystotome. Suddenly I see a blood vessel there. No, this could also be an artifactual now. It was not there earlier. Sometimes the flow of the fluid itself along the wire can cause on.
But how long distance from the T junction?
Okay.
The T junction?
So the whole procedure of wall of necrosis drainage by metal stent has 4 steps. The first step is puncturing and passage of guide wire. The second step is now I'm doing is passing a cystotome over the guide wire to create a fistula. Here comes my cystotome on top. It's here. I'll bring it closer and then I will pass the current. It's the same current that we use for ERCP at syntagmy. Here it goes in easily. So I've created the fistula now, and next step is now to dilate this part, that is the third step, with a small caliber balloon. And during each accessory exchange, I am keeping the guide wire always in my view, and that's a very, very important technical tip. So if somebody who is doing it should always keep the guide wire on your view, not to leave on the EOS image. So what is the balloon size you're giving me? 6 millimeter Titan balloon. So this balloon will go also on the guide wire. So you must have observed that I have not used endoscopic image at all. I am only doing under EOS image so for all the steps. And even this step also we can do under EOS vision. So here comes the guide wire. We can take help from okay, so here goes my balloon inside. Okay. Okay, inflate. So that's the dilated balloon. Still I am not using my endoscopic view. And this is the balloon from here to here. I can actually measure the diameter of what I have achieved by this balloon. About 6 mm or so. Is the stent ready?
Yes, sir.
So I will now start deflating the balloon. We don't want to keep it for 1 minute. Just enough for the assembly of the stent to pass in. So the third step is dilation, which I have done now. Again, not seeing my endoscopic view. So all the procedure can be done under EOS and taking help from the fluoroscopy view.
Yes, sir.
I'm keeping my guide wire in the view. My exchange is 1-to-1 with Srinivas, so he's pushing the wire and I'm pulling back the balloon. And it's come out now. So with time and experience, our coordination between the endoscopist and the technician is without telling also it happens. And that's a very good part of the teamwork. Along with that, we have Dr. Upinder Gaur, senior anesthetist. So he knows what I have to do and what I realize what he has to do. So he has nicely quietened the patient. While we are doing the procedure, he has tilted the patient in a head low position so that any fluid which comes out after the drainage will be easily aspirated by mouth, or the patient can smell it out from the mouth. It won't go into the airway. So keeping the head low position is also equally important because we have not intubated the patient. And the risk of aspiration always remains when the fluid gushes out. So here comes the stent now. An AIG stent over the guide wire. It's almost reaching there.
The patient in left lateral position or prone?
Here comes the stent. You can see that? So this is the assembly of the AIG stent, which will take a little more in screen. Okay. And then we will start deploying. Srinivas, can you just open the stent so the inner flange will open up? So you soon see an umbrella opening inside. That's the inner umbrella or inner flange of the stent. This stent is 2 centimeters long and it is fully expanded. But unexpanded stent can be 3 or maybe more also. Okay.
Sir, one question.
And now at this point I will switch to endoscopy view. For the first time in the procedure, keeping EOS view also and fluoroscopy as well. So my margin of error is very less, and that's why I have to be very, very careful when I deploy the stent, but I gently pull back the scope while pushing in the stent millimeter by millimeter. I am seeing the margin of the stent now. Okay?
Yes, sir.
So,
Sir, one.
release one. I was mentioned, just a minute, I'll just take a comment a minute later. Let me the most crucial part where I don't want the stent to be in perfect position. Half inside and half outside is what I want. And that's the stent getting deployed. I'm pulling back the sheath. The stent is opening up. Yeah, that's right.
That's nice.
Okay, it's partly inside. No problem. So these things do happen. Okay. So while talking this, the stent is not in a good position. I just realized that. So what I'm going to do is pull back the stent. So these things do happen when the little moment of lapse of concentration. This can happen, but I'm sure we'll be able to handle it. So while the fluid is gushing out, I'm trying to suck out the fluid. While Srinivas is arranging the rat tip force up to reposition the stent, which I'll pass now. So two mistakes happened, two errors happened. One was the guide wire got pulled out, which should never happen. I think my lapse of concentration helped. But you can see this is the gastric end. I'll catch it now at the edge, open, catch, and I'll pull back, release, not fully open. Huh? Last is not opening over, that's the reason I think. Huh? Let me catch its ear and give a tug there. Open, really open. So sometimes these things do happen when the stent does not open out. Let me open the edge.
Okay.
Release. Okay, it's opened up, not fully still, but at least more than what it was earlier. We'll also place a plastic stent. Give me a ball to that. Now you can ask the question. So I'm in a secure position.
Yes, sir. Sir, one questions from audience, and what about the position of the patients?
The position of the patient is in left lateral position. And that's the
Other questions from placement from G junction, distance from G junction, sir.
okay, distance of I just show to you. Let me show. This is somewhere in the mid stomach, mid body. It's now opened up well, much better now. Before that, so little bit of you have to, like a naughty child, you have to pull the ears. I think you have to do it the same. So that's the G junction here.
Yes.
You see that squamous junction is here. This is the palisading vessels. And then I go down about 5 centimeters below the G junction.
Okay, sir.
But I always place a plastic stent inside. Since my guide wire has come out, I will place a fresh guide wire and through a ball tip catheter. That helps in anchoring the stent and also prevents the debris to prevent clogging of the lumen of the stent.
So, another questions from the audience. What is the endoscopic station in this US?
Okay. So there are several stations described for endoscopic anatomy, for US anatomy. So from the G junction, mid stomach, antrum, duodenum, first part, second part, and third part, and also mediastinum. So lower part, mid part, and upper mediastinum. So at this time, I am in the mid stomach. But during drainage procedure, we try not to look at the anatomy part of it. We just want to look at the area of interest, which was the collection, and whether we can drain it or not. Because sometimes the normal structures will be hidden by the obscured by the. Can you pass it now? No. Can you pass? So this is really more tricky. No. Okay. So it's gone in. As you can see on the fluoroscopy. I'll pass a 7 French 4 centimeter double pictal stent. आगे हो जाता है. You can see the stent inside now, the inner part. Under there, how much cold service is there? The stent. So this stent, when you remove it. That's a very important question that you are asking. The first time we will keep this stent will be kept inside for about 3 to 4 weeks. By the time the collection will have totally resolved, and if need of necrosectomy is there because of the too much debris, that also will be over. So once the collection gets resolved, we'll remove it 3 to 4 weeks, and before removing, we'll do an MRCP to look at the ductal anatomy. Open. It's still more a little bit moved in and pulling it back. Okay? Okay, leave it. Now it's okay. Close. So after about 3 to 4 weeks later, we'll remove the stent. At that time, we'll also do a gentle pancreatogram to look at the disconnected pancreatic duct. So just to establish. As the MRCP will tell us that the MRCP, since it does not have the secreting part, or it's not a dynamic MRCP, we will not be able to know the exact duct contour. So you saw two procedures which had adverse event during the procedure. One known very nicely coagulate the blood vessel which was spotting, had polypectomy, and over here we have the stent which was really malpositioned, and if you have not grabbed in time, in few hours time, the stent would have gone inside the collection, and that would have caused a major disaster. So it's always better to keep your eyes and ear open and be alert. It is. So that's half the stent inside and half outside. With that, I complete the procedure. And now I can take all the questions and comments. Hi. You remove both the stent at a time? Yes. Yes. Earlier what we were doing was, in case the patient had disconnected that, we will only tease out the metal stent and leaving the plastic stent inside to prevent any recurrence of pancreatic fluid collection. But after our experience and detailed analysis of such patients, we realize that not everybody who has disconnected that will develop a recurrent collection. So there is no point keeping a metal stent or a plastic stent permanently. Metal anyway we have to remove. If the stent metallic stent go inside, what do you do? So that was a tricky area. So I made two mistakes. One was my guide wire got pulled out. I should never remove my guide wire till I am 100% sure the procedure is comfortable and I am happy with the position. And second was the stent was not in the right position. Because of the length is so small and the stent does not have so much strong lumen opposing capability, this can happen. But if the guide wire is inside, if the stent goes inside the cavity, I can go over the guide wire and fill it out, or at least over the guide wire I can place another plastic stent or another metal stent. And once the patient is okay, 1 or 2 days later, I can go inside the cavity and fill that out. Thank you, sir. But you positioned the stem nicely. Yeah, it's very nice position. That's what I wanted to do. Thank you very much, sir. Thank you very much for the excellent demonstration. We will go to the next case. The clinical history is a 65-year-old female who presented to us with right upper quadrant pain since 3 months and low-grade fever. The WBC is raised 16,300. Her LFT is bilirubin 5.8 with elevated alkaline phosphatase. The MRCP image we can see is distal CBD calculi is there with dilated proximal CBD and bilateral IHBRD, chronic cholecystitis and cholelithiasis. The plan is ERCP with biliary stenting and stone removal. Over to live transmission. Okay. Thanks, Abhik. So this is again a typical case scenario which you see in daily practice, where a female with obstructive jaundice, cholelithiasis, and the main thing what as the endoscopist one will be worried about is the post-CRCP pancreatitis. Of course, the age is on a little higher side, but nevertheless, female sex preponderance being there, so PEP is a very worrisome thing which we often think about. So what in our unit as a practice is we give rectal indomethacin to all the people who are undergoing this VRCP, which are already been done in this patient, and also we give IV river lactate solution 1 liter in an hour, so which is on flow. So now as you see here, I have taken a simple upper duodenoscope, and as you see the papilla is very nicely placed. Actually, it's a very juicy papilla for a pre-cut sphincterotomy, but nevertheless, I will just go in and a conventional sphincterotomy and then try to cannulate. So as you see here, there is a chance of the wire going into the pancreatic duct, but we will be ready to place a PD stent if at all it goes. But as you see, the papilla is wide open, and I will be trying to target the CBD between 11 to 1 o'clock, and that's where I am focusing myself in. Let me just put in the wire is already there at 11 o'clock position precisely. So I will just push in the cannulotome. Yeah. Can you flex the cannulotome, Madhu? Yes. So Madhu is assisting me. Yeah. Yeah. Okay. So it's slipped, no problem. So what I'll do, I'll come back and then try to go in again. Yeah. Okay. So I'm a little bit deep inside. Madhu can flex the sphincterotome. I will position myself in such a way that I try to get into the CBD. Yeah. Okay. You can push the wire, Madhu? Okay, so my assistant is doing the wire manipulation, and we are trying to go into the pancreatic common bile duct. You see here, so okay, it's good. So we have gone straight into the common bile duct, and now as you see here, because I avoided the cannulation of pancreatic duct, I should not be worried about, but nevertheless, even then, females, especially young females, you always have to have a PEP prophylaxis as a mandatory in your units, whoever is doing VRCPs. So now I will go deep inside. On MRCP, there is a distal CBD calculus, I presume. So what I am going to do is I am going to go deep inside of the common hepatic duct and then start the contrast filling. Can you fill the contrast? Okay. So now I am filling the contrast, and let's see where the stone is. So that is the proximal part of the CBD. I am just coming out, slowly filling the pancreatic duct. Yeah, as you see here, there is a distal CBD stone, fairly big one, right? So it's not occupying the entire CBD. Okay, so now I am very sure that there is no stricture and only a stone. So what I am going to do now is, you want to exchange the wire or you can just cut on the same wire. Okay, so what I am going to do is do a nice biliary sphincterotomy, take a wide opening and then try to take out the stone. Now as you see on the cholangiogram, can you see the cholangiogram please? So the stone is not occupying the entire common bile duct, and it looks like around 1 to 1.5 centimeters. I feel it should be out with a basket, but nevertheless we'll do a sphincterotomy and see what will be the next step. So now this is a clever cut sphincterotomy where we have the clever cut being there, and part of the sphincterotomy is covered with that cover. And you see I am just doing a gentle sphincterotomy up to the fold. It should not cross beyond that. Okay. So I have done that. I will just give a small nick, one more. Yeah. Right. Okay. So now I will go deep into and then position myself around the proximal common bile duct. And Madhu is going to exchange the wire. What we use till now is a thermo wire, which we will exchange the stiff guide wire. It will be easy for us to push in and pull on the accessories. And the stone, as you see on the cholangiogram, is fairly big, but I am sure it should come out with the conventional balloon extraction catheter. Okay, so can you just give me the balloon extraction catheter? Yeah. So now as you see, I am exchanging the sphincterotomy with the balloon exchange catheter. So my radiographer already has measured, and it looks like a 9 mm stone, that is less than a centimeter. Usually these kind of stones of this size should come out with the balloon extraction basket. Any questions at this juncture? Yeah.
What is the ideal time of giving rectal in the metacin?
See, usually
When that is,
usually,
before we are
between 30 to 30
hours or
usually 30 minutes to 1 hour. 30 to 45 minutes before you are.
Thank you.
Yeah.
Yeah.
So if you have a high
Bleeding, you get,
sorry?
there is a small amount of bleeding in that.
Yeah, that's okay. It should not be a worrisome because it's a self-limiting one. So what I'm doing now is pushing in the balloon extraction catheter, and then I know that a stone is there in the distal CBD. So my extend will inflate the balloon in the mid CBD, and now I'm just trying to come out. I will see here already there's some amount of black bile coming out. What we have to do is focus my hand position. What I'm doing here is I am giving a touch on the balloon and then rotating my scope so that the balloon will be out along with the stone. So what I have done is I just have taken a right turn with a little bit of touch on the balloon. So as you see here, the stone has come out, the single stone. Can you appreciate now?
Yeah, very nice.
So now, because the only single stone being there on the cholangogram, to double confirm it, what I will do is I will just go in and then do a nice sweep of the CBD from the proximal end so that if there is any tiny stones or any sludge, it will also be out of the convolution. Yeah. So now,
When you do sphincteroplasty along with sphincterotomy,
yes, so very nice question. So what usually of the stone, size of the stone, and also if there is any distal CBD narrowing, size of the stone usually will be 1.5. I am doing occasional cholangiogram as you see on the screen to confirm that there is nothing left as a filling defect. And as you see here, there is a little bit of sludge being there, so now the balloon is out. Can you see here? So now that I come back to your question of sphincteroplasty, but now I opt for going for biliary stent because this lady has got cholelithiasis and there is chronic cholecystitis. So surgeons sometimes might take a 4-week interval for the gallbladder wall edema to come down. So in this meantime, there should not be any other stones slipping from the gallbladder and getting stuck in the CBD. So for that benefit, I opt for a double pigtail biliary stent till the cholecystectomy is finished, and once the surgeons do out the cholecystectomy, I will put out the stent usually between 3 to 4 weeks. Can I have a double stent? Pigtail stent. Yeah. Coming to the question of sphincteroplasty, it depends on the size of the stone and also the nature of the distal CBD. Because size of the stone will be 1.5 to 2 centimeters. Then usually the balloon, the basket might not help in taking it out. Then we do the sphincteroplasty. And if they have a distal CBD stricture which is a non-malignant, which is confirmed in the endoscopic ultrasound, then we go for a balloon sphincteroplasty. So there are a few indications where sphincteroplasty is one of the good options to retrieve large stones.
yeah, thank you.
Yeah.
If the papilla is ligament, small papilla in this case,
Yes.
if papilla is
Yeah, if the papilla is in a odd position motion, then you have to have the ways of dealing with it. One is, if it is small papilla, then one option, if you cannot cannulate the sphincterotomy, is doing a pre-cut sphincterotomy. But actually, if you see this papilla once before we cut, it was very juicy papilla to do pre-cut sphincterotomy. Second is, if the stone is stuck in the papilla and it is very bulky, then the easiest way of tackling it is do a pre-cut and then the stone will slip out. That is one other thing. And if you have a small papilla where the cannulation is not possible, then those are the places where you opt for a pre-cut, or you try to do it by changing your wires from a straight wire to a angle wire and so on and so forth. So now you see the pancreatics or the biliary stent is deep inside, just taking a pigtail in the proximal CBD, and the lower CBD outside in the duodenum, I have left the second pigtail. Okay, so there ends the procedure, and I'm not worried about the little bleed which is there. This stent will be there typically for 3 to 4 weeks until the surgeons do a cholecystectomy, and then we'll remove it out.
Very nice. Very nice demonstration.
Thank you. So Hardik, if you have time, when Mohan is doing the poem there, we can switch on to the other theatre.
So we can take some questions.
Yeah,
If you go to the next room.
Yeah. Sure. Much any questions from the audience or your end?
Yes, sir. At this moment, sir, one question, sir, regarding that is balloon sphincteroplasty, that is large balloon sphincteroplasty.
Yes.
What the conditions should be considered before doing sphincteroplasty?
Yeah, that's what I told you. Stone size more than 1.5 to 2 centimeters. Then a distal CBD stricture or narrowing, which is benign. And third, when you have multiple stones, which you have probably narrowing it with a lithotripsy, and if you want to extract the multiple embedded CBD stones sludge, then we do sphincteroplasties. But again, sphincteroplasty is how much you have to. Sorry?
How much you have to inflate the balloon?
Yeah, it depends. You have the balloons of different sizes, and diameter of the balloon, what it should, depends on the morphology of the papilla. If the papilla is small, probably 12 mm is good enough because it should not end up in perforation. If the papilla is bulky, then you go up to 15 mm. So it depends on the anatomy of the morphology of the papilla also. It's not a standard fixed that you have to do only 12 or 15.
Thank you very much, sir, for the excellent demonstration. We'll go to the next case. The clinical history is a 40-year-old male with history of dysphagia since 2 years with intermittent regurgitation of solid food particles. On evaluation, endoscopy had a dilated mid-esophagus. The manometry showed pan-esophageal pressurization with raised IRT fitting into type 2 echalalia, and the barium also showed a dilated esophagus. The plan is per oral endoscopic myotomy. Over to live transmission, sir. So you're live.
Yeah. Thank you. So here we are with the poem case. So first thing which I see is what is the type of echalalia? So it is type 2 echalalia. And then the G junction is at 35 centimeter. So I'll do a very small myotomy, maybe 4-5 centimeter myotomy. So I come back around 8 centimeter above the G junction, and then we inject the saline posteriorly. This you can see the spinal bulge on posterior wall at 6 o'clock. So this is 6 o'clock, and Mohsin, can you see the vertebral bulges? Yeah, so that is 6 o'clock. So we'll inject the saline at 5 o'clock position to do posterior myotomy. Okay, we can see nice mucosal bulge over there. And then we will cut this mucosa to enter into the submucosal space.
Why you choose the posterior one?
So anterior and posterior both are equally effective. Posterior is technically easy. As you see, the accessory is coming out at 7 o'clock position, and it is very easy for me to do the incision at 5 o'clock position. But if I want to do incision at 2 o'clock position, I will have some angle. So this is slightly difficult, but this is very easy. So posterior is easy, however, the effect is equal. So you can see now we are making a mucosal incision and we are doing some dissection to enter into the submucosa because it is not easy to enter. So you have to do dissection like this as I am doing here. So once I open this submucosa, then it's easy for me to dip in like this. You can see now it is inside the submucosa, and then we will use the spray coagulation to dissect. So first of all, stretch this submucosa and then just do the dissection. Okay, so see that now we are into the deep submucosa. Still the boundaries between the mucosa
and muscle is not clear. Now we have got entry into this, so we will just remove these fibers centimeter by centimeter, and we'll keep on moving forward, vertically downwards. So you can see now I'm just bending the scope a bit to get into the mucosa there, and then I will show you some of the muscle fibers. Here, that is the muscle fiber. And then you have to bend your body to completely dissect it. To expose the muscle is very important because you should be near to muscle. And you can see at 6 o'clock position is the muscle. So I'll expose this muscle for you so that the anatomy is very clear. So now the anatomy is very clear. So this is muscle, this is submucosa, and there is mucosa. So I don't have to go towards mucosa. So I only dissect on the top of muscle so that I don't go towards the mucosal side. So see that wide dissection is important, otherwise your scope will not go. And you don't have to breach the muscle. But still there are chances that muscle may be breached. So I'll inject here, expand the submucosa. This is the submucosa being expanded. And then we again go into this direction, peel off the mucosa from the muscle layer like this. You can see some vessels were appeared there. So we'll grab this vessel and that vessel with the quick grasper, and then we can coagulate these vessels, and the chance of bleeding will be minimized. Always keep the operating field very clean. Don't allow this to ooze. You want to know? So you can see that now I am coagulating this vessel like soft coagulation as we did into the polyp case, and cut it. And then we can tackle this vessel also. Close. You can see, allow that to blench, become very white like a thread. And once it happens, you cut it by using endocut. It's very easy. And see that there is no bleeding and the operating field is very clean. Posteriorly you can see the muscle, anteriorly you can see the mucosa, and in between the blue fibers are the loose areolar tissue of submucosa. So always keep on defining the anatomy, otherwise you may create some mucosal injuries, and then that will be a problem. So always define and go, define and go. So that's what I am doing. Keep on, and whenever there is, there is not a clarity, we inject the saline, make the submucosa more prominent, and then we go for. You can see here. So we'll go more forward like this. Again inject here. And we should always know where we are. So we'll just go out of the tunnel to know where we are. On the right side you have to move your body to complete this dissection, and then you come back from right to left. So first go to the extreme right, catch those fiber, don't go too deep, and just remove this loose areolar tissue so that you create a path for yourself to go deep. Okay? So I think I am in the stomach now. So we will go like this, out. So these fibers are not allowing me to go, so I'll just dissect those fibers and then go slightly more deeper. You can see now the gastric muscle is being exposed there, and these fibers in the corners are important because they will not allow you to go otherwise. So complete the dissection in the full arc so that your scope goes easily, and if suppose it is not going, then you have to do some dissection, release some muscle, and then go inside again like this. So again we'll inject here. So the plan is to keep on injecting, keep the mucosa away from the operating field, and then go inside like this. So I am at almost 35, so just around the G junction. So we'll go inside the lumen to see where we are. Sometimes it is very difficult to ascertain whether we have gone beyond the G junction or not. So it's always important to know what is your vertical length. So we have gone right into the stomach. So we'll come back and see where we are. You can see this nice tunnel, and then you come out, and then you see this bluish discoloration of the tunnel at the G junction, and then we will retroflex to see where we are. And you can see the blue color right at the up to here. Can you see, Mohsin, the blue color of the tunnel? So the tunnel has traveled right into the 2 centimeter into the stomach. So that means our 1%, yeah. That's all. And how you can see we are in the right. Say it again, Mohsin. Right. So we are on the right and sure. Yeah, that's a good question. So if you expose the muscle fiber like this and make a imaginary perpendicular line to this circular fibers which are there, then you will always go into the right track like this. But if you don't make a perpendicular line or angulated line, you will go into wrong track. So always expose the muscles and go into perpendicular, imaginary perpendicular line to this circular fibers. Okay, sir. So another question, how we can differentiate between the esophageal muscle fiber and external muscle fiber? That's very good question. That's very good question. So if you see that on esophageal, there are other some muscle groups. So I am cutting this muscle. I'll show you how to differentiate between the esophagus and muscle and the gastric muscle. So first of all, you have to cut the fibers like this. That is that you can see the earliest. We got a lot of. That is a. So we are cutting the muscle fibers at the LES, and then we are into the stomach now. So this is the posterior mediastinum, and this is the muscle fiber, and this is the submucosa, and this is the mucosa. So you should not touch the mucosa. So that is the circular fiber only. No, we cut both. You can see now we are into the peritoneum and we completely cut. So if you want to go a centimeter more, you can inject here. Sometimes you are not satisfied with the gastric length, so you can do some more dissection and cut the muscle fiber like this. This is the submucosa which you can cut, and then additionally cut the muscle fiber like this. So now I think I am gone enough to 3 centimeter, and this is the peritoneum. This is the peritoneum, and this is the muscle layer which is completely gone. This is the mucosa, and above one is the mucosa. You can see now complete separation of muscle has been achieved, right and left margin. The above mucosa is covering that. So you can see now how well the LES has relaxed. Muscle is it? You can see how well the mucosa has relaxed and the LES is completely open now. Okay. So now we'll clip it. What about the pardon? And what about the left of intragastric part, sir? So intragastric part is around 3 centimeters. No, don't go more than 3 centimeters into the stomach. So we will now quickly close this because we have completed the myotomy. And now we are closing this mucosal incision. You can see I am applying the clips. The first clip to be applied on the normal cut surface, and then that will create a lift for you so that subsequent application of clip is easy. So open and then open completely, and then bring this clip on the right and left margin of the first clip, and then press it and suck it and apply. So you can see how nicely both the edges of the cut mucosal surface are being approximated, and there is no need to worry because the muscle incision has started after the completion of mucosal incision and the muscle behind is intact. And you can see now we are applying the third clip. Yes, Mohsin? Do you do after poem and do you use the even that? We don't do in a routine manner, but if the patient is symptomatic, we do the evaluation for the GERD, like the pH between. So what is the fate of these clips? The clips will later. No. After some time they get removed because we also do it for our hemoglobin. We don't bother about these clips because they will automatically fall off. Yeah. Okay. So this is the last clip to be applied here. Section, and then you can see this incision is completely closed like this. Both the edges are now nicely closed, so we'll go inside and suck out all the air from the stomach because now the patient will be extubated, so the stomach should be collapsed so that it does not interfere with the respiration. So I have with me Dr. Harnath. He is our anesthesiologist who takes care of POEM patient. Mr. Srinivas, who has helped me in doing this procedure. And you can see nicely the LES has completely opened up and there is no mucosal injury. Most important is to identify the mucosal injury. If there is any mucosal injury, one should quickly clip it because now you have opened the mediastinum, you have opened the peritoneum, and the mucosa is the only barrier between those two. So one has to be very, cautious in not breaching the mucosa, but suppose something happens and mucosa is breached, we should clip it completely. And this patient will be kept nil by mouth for next 48 hours, 24 hours. Then we'll do a barium swallow to check for any leak, and then she can go home. Thank you. Yeah, thank you so much. Thank you, sir. Starting with this, thank you, Mohsin. Thank you very much. Any questions, we'll be happy to answer. Okay, sir. Okay, thank you. Thank you very much, sir. Classic demonstration. So this was our last phase for presentation from AIG today. Thank you. Thank you. Then you also navigated this side and one side. Thank you. Thank you. See you soon. Thank you. Our sincere thanks to Bangladesh.
Okay.
Stay safe, sir.
Oh, thank you. Thank you.
Now, I'd like to invite Professor Subhankar sir for his welcome address. Though it is little there is some changes of program. Now I'd like to invite Professor Shapan Chandra sir for his welcome speech. Sir, Shapan Chandra sir.
Professor Shapan Chandra, please unmute your mic and give your space.
Thanks. First of all, I'd like to thank the speakers, Professor Dr. G. and Reddy and Professor Bharat for their excellent speech. Professor G. and Reddy needs no introduction. He is a very renowned gastroenterologist throughout the world. I should say throughout the world. And he is very close to us and for many 12 years. A lot of programs have been arranged with Professor G. and Reddy and with AIG Hospitals. He has greatly expect the role of ESCP in acute biliary pancreatitis, which we learned too much from his lectures. He will also emphasize the importance of EUS before doing ESCP in acute biliary pancreatitis. Thanks Dr. Reddy for his excellent deliberation. We hope again to meet him in the future. Second speaker, he has very deliberately told about the risk assessment and safety figure of ESCP. He has greatly explained all the factors and predictors responsible for high-risk procedures and safety of the procedures. He has told many safety factors to look at before doing investment in ESCP. So, then, patient selection, selection of patient is very important, and indication of ESCP is very important. Indication of proper indication of ESCP is also very important. And here also explain about all the complications that is what can happen during ESCP. So I like to thank Dr. Farooq for his brilliant presentation. Dr. Farooq also did not introduction. He is very eminent gastroenterologist in our country, and he is the director of Gastroenterology Institute of Bangladesh, and he is the secretary of Bangladesh Society. So I'd like to thank Dr. Farooq again for his brilliant speech. Thirdly, I'd like to thank the AIG team for several excellent therapeutic and research procedures. And a lot of things we have learned from their work. And I think our junior gastroenterologists will be very much benefited from their lecture. And I like that. I think that our junior gastroenterologists will follow their path. And some of the younger gastroenterologists should take decision to take over these initiatives for near future in our country. Because I think somebody should take initiative to be a good therapeutic endoscopist. Also, there is clinical gastroenterologist. Now, I think some of our young undergraduates should take the decision. Who will go to clinical gastroenterology and who will go to therapeutic endoscopy. And I think today, good endoscopy, like those of AIG hospitals, they should stick to only therapeutic endoscopy and should take training from different institutes like AIG hospitals and other countries of the world. Last of all, I thank the reporter and audience for the keep patience and patience sharing. Thank you all for your patience sharing. Thank you all.
Thank you, sir, for your nice speech. Now, I'd like to invite Professor Dr. Mohammed Hamid.
Assalamu alaikum and very good evening. I'm honored to be a member of panel experts. We are all very much lucky to have the opportunity. Can you hear me? Everyone. Excellent. We are all very much lucky to have the opportunity to learn from our AIG experts through lectures and their live demonstration of different procedures. They are sharing easy techniques and their experience. These learning sessions are stimulating our gastroenterologists to be an expert one like them. We hope this type of learning session will be arranged in future. We also need cooperation from Professor Reddy sir and his team of AIG in future, like previous years. If we get guidance and help, our gastroenterologists can also improve their expertise and serving our people. Special thanks to Professor Reddy sir and Professor Farooq sir for their nice lectures and AIG experts for their nice practical demonstrations. Special thanks to Mr. Basu, Mr. Maksud and Mr. Shafiul of Sun Pharma for their beautiful arrangement of eSPACE learning. Last of all, hope to see all participants in the next session. With this, with Allah.
Thank you, sir, for your nice remarks. Now, I'd like to invite Professor Dr. Ashaduddin sir for his concluding remarks.
Good afternoon, everybody. At the beginning of my remarks, I must thank the organizer for selecting me as a panel member in this auspicious session organized by Bangladesh Society and Asian Institute of Gastroenterology. We learned a lot from this session, also previous sessions between this collaborative effort at AIG and BGS. Dr. D.N. Reddy sir, we all know, the leading legend in gastroenterology, delivers his speech in an extraordinary manner. We learn a lot from this lecture. We know that he delivers always in lecture his lecture is always informative, and almost all lectures are practical oriented. But our gastroenterology colleagues learn a lot from this lecture. Thank you, Dr. D.N. Reddy sir, for your nice deliberation and continuation of collaboration between the AIG and BGS. Our second speaker, Professor Farooq Ahmed sir, is one of the mentors and key person in Bangladesh Gastroenterology Society. He is continuously trying to improve our clinical knowledge, also therapeutic interventive knowledge by arranging meeting between different society, between BGS and British Gastroenterology Society, between BGS and AIG. Thanks to Professor Farooq Ahmed sir for his nice and informative lecture. We learned a lot from this lecture. Finally, I'd like to thank the AIG team for their nice deliberation. also the learned audience for their patience here. And also, I like to thank the moderator for his nice moderation and Sun Pharma for their scientific sponsorship between this collaborative effort. Thank you all. Thank you, sir, for your remarks. Now, I'd like to invite Manjay Basul for all things.
Your instead of Sanjay, myself, Anil is here. Hello. Yeah, sir. Thank you. This Professor Dr. Sapir Chandra, Professor Dr. Mohammed Jamal, Dr. Eshadin Ahmed, and all our most valued officials from Bangladesh. On behalf of Sun Pharma, I would like to extend my sincere gratitude to all of you for your gracious presence in this far live webinar on eSPACE Endoscopy Masterclass Section 5. I'm sure all of you will join me in thanking Dr. Nageshwar Reddy, Professor Dr. Farooq Ahmed, and Team AIG for their excellent presentations and demonstration on live procedures. Thanks to Mr. Satya to provide us all the technical support for this virtual session. Special thanks to Dr. Mustafa Noor Martin for moderating today's event in a stainless floor. I would also like to profusely thank on behalf of Sun Pharma participants present here for gracing this occasion in spite of this challenging time. It was indeed our privilege to have you all here. Also, like to thank you for continuing your confidence in Sun Pharma products and extending their benefits to your patients. Thanks a lot for your great support all these years. Thank you all for being our nation's guiding light in the face of this adversity. Last but not least, I would like to extend my sincere gratitude to all of my fellow colleagues, the team of very motivated and dedicated athletes of Sun Pharma. Thank you to Sun Pharma. Again, thanks